Good morning, everybody, and welcome to our last lecture on head and neck embryology. Today we're going to look at the last part, and that is development of the tongue and palate. Should be quite a quick and relatively straightforward lecture today. So let's begin. So, like I just mentioned, we're just looking at two main things today. So looking at the development of the tongue, and within that we'll discuss things like the innervation, the musculature, and secondly, we will look at the development of the palate, and within that we'll look at things like the development of the intermaxillary segment, the secondary palate, and so on and so forth. Okay then, so let's jump right into it and discuss the development of the tongue. So the tongue first appears at approximately the 4th week of development. And what happens is at that four-week mark, the structures that eventually become the mucosa of the tongue start to develop from these pharyngeal arches. So if you remember this image of the pharyngeal arches developing from a few lectures ago, you'll recognize that this area denotes the first pharyngeal arch. This would be the second pharyngeal arch. This is the region of the third pharyngeal arch, and this is the region of the fourth pharyngeal arch. And as the tongue is developing here on this image on the left, you can see that the different parts of each pharyngeal arch is denoted by different colors are kind of giving rise to different parts of the tongue. So the tongue receives contributions from 3 swellings, all right? And these are going to be the median tongue bud as well as 2 lateral tongue buds, which are going to form, and they're going to start growing very rapidly, and eventually they're going to merge together to form this sort of one big main tongue structure by the end of the 5th week of development. But to delineate this a little bit more and to better understand how this development is happening, we're going to divide the tongue itself into the sort of front part, if you look at this image on the right. So it's anterior 2/3, this little bit in orange, and this posterior region, or the posterior 1/3 region, in yellow back here. So specifically, if we look at the anterior 2/3 of the tongue, so this orange part here, we just mentioned that the tongue appears in embryos as 2 lateral lingual swellings, and you have 1 medial swelling in the region of the anterior 2/3 of the tongue. Now, this medial lingual swelling, as you can see coming back to this image on the left, it's labeled up here for you. This medial lingual swelling is called the tuberculum impar, and that's spelled out up here. What happens is that its appearance is the first indication of tongue development. Now, all these 3 structures, so the tuberculum impar and the 2 lateral lingual swellings, so you have one here on the left and then one here on the right. So the 2 lateral lingual swellings and the 1 tuberculum impar, they're actually from the first pharyngeal arch, as you can see in this image over here. So what happens is that the lateral lingual swellings are going to start growing, and they're going to increase in size so much so that they eventually sort of overgrow and become larger than the size of the tuberculum impar in the middle. And of course, as that kind of continues on, you can sort of see this transition here between the image on the left and the image on the right. So as these lateral lingual swellings have kind of grown a lot, they've grown a little bit more than the tuberculum impar in the middle. In fact, they eventually merge, and the site of fusion of the 2 lateral lingual swellings can actually kind of be observed on your tongue, your own tongues as well. So if you have a little look, if you hold up a little mirror and you have a little look at your tongue, you will notice that that part where the two lateral lingual swellings came together and merged is actually indicated by the midline groove on your tongue itself. And that's where the lateral lingual swellings fused. And with that, you have the formation of the anterior 2/3 of the tongue, or the body of the tongue. All right, so the mucosa of the tongue, the anterior 2/3 of the tongue, is derived by those two lateral lingual swellings of the first pharyngeal arch, and of course the tuberculum impar of the first pharyngeal arch as well. Now, what about if we move on to this yellow part here, the posterior 1/3 of the tongue? So if you look over here to the image on the left, you notice this sort of middle region known as the copula. And this is basically the third pharyngeal arch's contribution to the formation of the tongue. So what happens is that the copula will proliferate, and it ends up kind of overgrowing really beyond the region of the second pharyngeal arch. And it's sort of that little bit of overgrowth to take over that region of the second pharyngeal arch so it can, kind of merge up with the anterior 1/3 of the tongue. That's really what gives you the posterior, the mucosa of the posterior 1/3 of the tongue. So basically, now that we have developed, you've got the anterior 2/3 and the posterior 1/3, and they're completely developed. They eventually fuse together. And what happens when they fuse together? So when they fuse together, as you can appreciate on this image to the right, you can kind of notice that they form this sort of, it's almost like a wide V-shaped groove. And this wide V-shaped groove, as it's labeled up here, is the terminal sulcus. And this is the sort of dotted line area between the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. And this is known as the terminal sulcus. Now, sitting kind of exactly in the middle of the terminal sulcus, we have the foramen cecum, which, if you recall from an earlier lecture we had in our second lecture on the development of head and neck embryology, foramen cecum is actually where the thyroid gland originates from, and it kind of sits here in the middle of the terminal sulcus between the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. Now, because we're already in this region, as a side note, I will also share that the third median swelling that is formed by the posterior sort of region of the fourth pharyngeal arch will start to proliferate, and it will ultimately, if you kind of compare between images 2 and 3, you'll notice that that green part will eventually mark the development of the epiglottis. And this sits immediately behind, and sitting immediately behind this epiglottal sort of swelling is a sort of black region here where you have the laryngeal orifice, and kind of flanked on either side by the arytenoid swellings. So that's really just it. That's really just how the muscular part of the tongue develops. So the first pharyngeal arch gives rise to the anterior 2/3 of the tongue. The second pharyngeal arch has a bit of an initial contribution to the surface of the tongue, but this contribution is eventually lost, and you can really appreciate that between these two images on the right and left, where the second pharyngeal arch was denoted in blue here, but you notice in the final structure of the tongue on the right, we've kind of lost that blue color that was the contribution from the second pharyngeal arch. The third pharyngeal arch gives rise to the posterior 1/3 of the tongue, and the fourth pharyngeal arch, of course, gives rise to the epiglottis and its sort of adjacent regions. Okay, so what we saw just now was really how the mucosa of the tongue develops. What about its musculature then? So just a brief mention. We don't really get into the nitty-gritty of this, but just to briefly mention so you have like a clear overview of the development of the tongue. If you can recall, the tongue actually has extrinsic muscles and intrinsic muscles. And where do these muscles actually, where do they come from? Where are they derived from? So if you answered occipital somites, you would be right. So remember the occipital somites we had that sort of sit in the region of the upper neck during development. We don't really discuss the somites so much for the purposes of head and neck development for medical students, but just to have a brief idea is that those occipital somites in the region of the neck during development, they start to migrate from the neck sort of anteriorly towards the region where the tongue will later on develop and ultimately give rise to the muscles of the tongue in that region. Okay, so now that we have the mucosa covered and we have the musculature of the tongue covered, let's have a quick look at its innervation. So the tongue is actually innervated by a range of cranial nerves, and I've summarized that for you up here in this little box in blue. And these include basically the trigeminal nerve or its lingual branch, the facial nerve or its chorda tympani branch, as well as the glossopharyngeal nerve and the hypoglossal nerve, which actually innervate the motor components of the muscles of the tongue. So with the hypoglossal nerve specifically, it provides motor innervation to the muscles of the tongue. So that includes both, of course, the intrinsic muscles of the tongue as well as the extrinsic muscles of the tongue to allow for things like rolling the tongue, protruding the tongue, retruding it, that sort of movement. And the way our tongues are innervated is actually not so commonly found in the tongues of other mammals. And of course, this is because of the different, these sort of different innervations of the tongue allow for the sort of fine motor control of the shape of the tongue that we have. Okay, so let's try and correlate, or rather maybe just tie together what we just mentioned about the innervation of the tongue and what we discussed 2 weeks ago in our first lecture about the development of the head and neck. So if you can remember, I shared with you that each pharyngeal arch is actually associated with its own cranial nerve. So just to do a quick recap of that. So again, looking over here to the right, you have pharyngeal arch 1, pharyngeal arch 2, pharyngeal arch 3, and the fourth one down here is pharyngeal arch 4. So just to recap, the first pharyngeal arch is associated with the trigeminal nerve. The second pharyngeal arch is associated with the facial nerve, and the third pharyngeal arch is associated with the glossopharyngeal nerve, if you remember this from earlier. Now, if we take this information and we apply it to the development of the tongue, you'll notice that the sensory supply to the mucosa of the anterior 2/3 of the tongue is from the trigeminal nerve. And this should make sense because as you can see here, this first pharyngeal arch is what gives rise to the anterior 2/3 of the tongue. So it makes sense that it would get its sensory innervation from the nerve that's associated with the first pharyngeal arch, which is the trigeminal nerve, or more specifically, the lingual branch of the trigeminal nerve. Of course, remembering though that taste sensations are actually supplied by the chorda tympani branch from the facial nerve. Now, what about the second pharyngeal arch. Now, the cranial nerve that's associated with the second pharyngeal arch is the facial nerve. Now, the second pharyngeal arch doesn't actually innervate any of the tongue mucosa, because if you remember, what actually gives rise to the posterior 1/3 of the tongue is the copula, right? And the copula comes from the third pharyngeal arch. Remember how that copula actually overgrows beyond that second pharyngeal arch. So what is then innervating this posterior region of the tongue, the posterior 1/3 of the tongue, is actually the glossopharyngeal nerve, which, if you remember, is associated with the third pharyngeal arch. So that's really it. So the lingual branch of the trigeminal nerve providing sensory innervation to the anterior 2/3. You have the glossopharyngeal nerve kind of providing that innervation to the posterior 1/3 of the tongue. The chorda tympani branch of the facial nerve providing sort of taste sensations. And what about then motor innervation, or the movement of the tongue, or the tongue musculature, which I mentioned just a couple minutes ago? That is going to be innervated by the hypoglossal nerve. And that's because we mentioned that, if you remember, all the muscles of the tongue are derived by the occipital somites, right? So just a quick actually mention here then that all of the muscles of the tongue are actually innervated by the hypoglossal nerve, with one exception, and that is the palatoglossus muscle, which is actually innervated by the pharyngeal plexus fibers and not the hypoglossal nerve. Now, the last thing to note about the tongue is the presence of this structure running down the middle here on its underside, or its inferior side, and that is the presence of a lingual frenulum. Now, a frenulum is basically a fold of integument or a mucus that in a way helps to limit the movement of the tongue. And what actually happens during development is that because of apoptosis, or another word for apoptosis is programmed cell death, the tongue is actually released from the floor of the mouth. And as it's released from the floor of the mouth, what's kind of left here in the middle is the lingual frenulum, which will help to hold, anchor the tongue down to the oral cavity. So you can imagine that the position and the length of the lingual frenulum can actually have quite a lot of effects on things like speech or postnatal feeding of the infant. And we will explore some of these a little bit when we talk about clinical considerations in our later slides. All right, then, so similar to other parts of development that we've already discussed, certain things can possibly go awry during development of the tongue, and these things could have certain clinical implications later on. And in the case of the development of the tongue, some of these might include conditions like ankyloglossia, or sort of clefting of the tongue. Now, if we talk about ankyloglossia first, that's in this image down here at the bottom left. In ankyloglossia, basically the tongue isn't completely freed from the floor of the mouth. So, as I briefly mentioned in the previous slide, in normal regular development, the tongue is basically set free or released from the floor of the mouth. And the one structure that's left to hold the tongue in place is the lingual frenulum. So what happens in ankyloglossia, and the term itself really means tongue-tied, it's basically the condition wherein the lingual frenulum, so you can see down here, is actually quite short, or it measures less than 2 centimeters long. And this is a problem, excuse me, and this is a problem because it limits the ability or the range of movement that the tongue has. And of course, when the tongue has sort of limited range of movement, this might affect the child's speech development. But this can be corrected through surgical intervention where they just go in and this ankyloglossia is released. Next, we'll have a quick mention of bifid tongues or a tongue that has a cleft in it. And in this case, it's typically, you can notice it's happening, excuse me, on the anterior two-thirds of the tongue. And if you remember the development of the tongue, the anterior two-thirds are formed by those lateral lingual swellings kind of coming together and merging, right? So through that idea, then we'll realize that how a bifid tongue forms is that typically there is sort of an incomplete fusion of both of the lateral lingual swellings, and that may result in sort of a cleft tongue, or in some cases, if there is maybe like a more complete lack of fusion of the lateral lingual swellings and it kind of goes on further back, it may even give the appearance of two tongues, or otherwise known as a bifid tongue. All right, then what about macroglossia? So in the instance of macroglossia, which is this image over here on the top right-hand corner, the tongue appears abnormally large at birth, and this might be associated with a few different things. Now, sometimes it can be due to an undergrowth of the rest of the mouth, and of course, if that is the case, it's not true macroglossia, and this sort of condition typically tends to self-correct during the postnatal growth of the jaws when everything kind of gets larger. Then the tongue itself will fit better within the oral cavity. But true macroglossia might be associated with genetic abnormalities like trisomy 21. And in some instances of macroglossia, certain sort of surgical intervention might be necessary to help to reduce the size of the tongue, which might then in turn help to improve speech and the ability to chew. Because in macroglossia also, the frenulum tends to extend to the tip of the tongue. And in microglossia over here on the bottom left corner, patients with this condition tend to have an unusually small tongue, which itself might lead to difficulties related to speech and swallowing. And this might occur as a result of inadequate fusion of the lateral lingual swellings we saw from that first pharyngeal arch, which gives rise to the anterior two-thirds of the tongue. Microglossia can also sometimes be associated with a cleft lower lip. All right then, so now that we've reached the end of the section on the development of the tongue, just to summarize real quick what we've discussed so far is that the tongue basically develops from contributions from those first four pharyngeal arches. So you have the first pharyngeal arch giving rise to the anterior two-thirds of the tongue, whilst arches 2, 3, and 4 will in either some very small way like arch 2 or in the larger way like pharyngeal arch 3, which gives rise to the entire mucosa of the posterior one-third of the tongue. These contribute to the development of the posterior region. And of course, it's understanding these different pharyngeal contributions that help to also guide the understanding of the innervation of the various parts of the tongue. Okay, so the development of the palate then. So if you recall from our second lecture on the development of the head and neck, you might still sort of recall some prominences we discussed, and it might be good at this point for you to go back and maybe revise that second lecture on head and neck embryology a little bit before continuing on with the rest of this, because it does take a little bit of recall work. So if you can recall now, as a result of growth of the maxillary prominences starting to come together in a sort of more medial direction, and the two medial nasal prominences we had that are able to kind of merge together. And this sort of merger forms not just the philtrum of the lips, if you remember, but on a deeper level, the maxillary prominences and the medial nasal prominences actually fuse on a deeper level to form what is known as the intermaxillary segment. So let's take a more sort of zoomed in look specifically at this central portion called the intermaxillary segment. Now, this area gives the intermaxillary area is actually important for a few different reasons. And to summarize it, it's basically the triangular area, sort of triangular area rather, that will help to separate the developing oral cavity from the developing nasal cavity. And it's essentially the region that's going to also later on help to carry the four maxillary incisors. And at this stage, it's worth it to note then that the intermaxillary segment itself, so this whole region here, is actually primordial in nature, which simply put means that as development progresses further, the intermaxillary segment itself will cease to exist. It will no longer exist, but rather its parts remain as the different components that it gives rise to. Now, I'll explain this in detail in the next slide. So I mentioned that the intermaxillary segment arises because you had the medial growth of the maxillary prominences, and eventually that allowed for the maxillary prominences to fuse with the medial nasal prominences. And I also shared that the intermaxillary segment is primordial in nature. But what actually remains are its components. So what are these components? And I've summed those up. I've summed up its three components in this box on the lower left. So firstly, it has a labial component that will form the philtrum of the upper lips. It will have an upper jaw component, which holds the four maxillary incisors, and it has a palatal component that is going to contribute to the connective tissue plate of triangular shaped back here primary palate that we will get into in a moment. And that's really all we need to know about this primordial intermaxillary segment, is that each of these components are important. It's got three. One is the labial component, which gives rise to the philtrum. One is the upper jaw component, which holds the four maxillary incisors. And the last is the palatal component, which gives rise to this primary palate. Okay, great. So now that we have been introduced to the intermaxillary segment, and we know that one of its components gives rise to the primary palate, let's take a look at the development of the secondary palate. So, of course, as the face is growing, what happens is that that primary palate that we have eventually becomes far too small and short to adequately, separate the nasal cavity from the oral cavity. So instead, you need a new structure to form, and this new structure is called the secondary palate. So let me explain this to you. We have those maxillary prominences, right? Also referred to processes. Maxillary process or prominence are really the same thing. So those maxillary prominences that we learned about in our second lecture, by the time we get to about week 7 or week 8 of development, what happens is that these maxillary prominences expand quite a fair bit, and they give rise to these sort of medial extensions known as palatal shelves. So palatine shelves or palatal shelves. And these palatal shelves start to grow toward each other. And at the same time that these palatal shelves start to grow, towards each other, a few things also kind of start to happen simultaneously to allow these palatal shelves to kind of reach each other, because because they're growing towards each other. Other things need to happen for them to actually be able to reach each other and fuse with each other. So this is a bit more visual, sort of imaginary work. So let's try to all visualize this together. So looking at the oral cavity, right? The space within the oral cavity, you can even actually make it out in this image, is really quite small. It's not all that much. So in order for all these, palatal structures to come together, that's one, and then to number two, be able to fuse nicely together, some other structures need to move out of the way. So what's first? One of the first major obstructions we'd have in this exact region would be the tongue. So that is one of the first things that's in the way of these two palatal shells meeting and being able to fuse. So the tongue basically has to move out of the way. And so what does it do? In order to be able to start to move out of the way, it first contracts a little. But as it contracts and it's starting to try to make space, simultaneously what's happening is that the developing mandible, which has been removed in this image, also has to make space too. So this is all kind of happening at the same time. So the mandible drops a little and it starts to grow in this sort of more downward and forward direction. And the fact that it drops and it starts to grow in this downward and forward direction, it also starts to expand in size. So this sort of expansion in size also leads to an expansion in the size of the oral cavity. So now you can start to kind of imagine it slowly, right? So the mandible has dropped, it's increased in size. That means the tongue can now move down a little bit further. And there is now this sort of space available at the region of the roof of the oral cavity for the palatal shelves to kind of continue to move medially and to be able to fuse with each other above the tongue to kind of actually form a roof for the oral cavity. So if you can imagine it then, in like the sort of horizontal plane, you have the palatal shelves coming together. But what's also happening in a vertical plane is that you have the nasal septum moving and growing kind of downwards until eventually it meets with the palatal shelves. And so this fusion is happening in two planes. So in the vertical plane, you have the nasal septum coming down to fuse with the palatal shelves, and in the horizontal plane, you have the palatal shelves coming together to fuse with each other. So the fusion that occurs with these palatal shelves, as well as the primary palate, is that they are first going to, fuse at the front, and sort of like a zipper, they zip shut in an anterior to posterior direction. And this zipping shut creates this sort of unbroken hard palate that sits, on the floor of the nasal cavity and forms the roof of the oral cavity. And just as a side note here, the central region where the primary and secondary palates actually fuse together is later on going to be marked by the incisive foramen. And that's a foramen, which means that it's a hole it's a hole in the bone actually, through which blood vessels and nerves are transmitted between the oral and the nasal cavities. And at the end of all of that, if development goes off without a hitch, we ultimately have a hard palate and a soft palate sort of extending off its more posterior portion. Okay, so let me show you this video here, which hopefully explains it. So you can, this sort of short animation basically shows the inferior view of that developmental sequence we just talked about, from a position where obviously the mandible has been removed here, and you can only see the roof of the oral cavity, the maxilla over here, and a little bit of the upper lip. So this animation is basically trying to illustrate the right and left maxillary processes of that first pharyngeal arch, these processes, they come together, they fuse, and ultimately the secondary palate forms when these palatal shells are able to come together towards the midline and fuse as well. And then you have that zipping up from an anterior to posterior direction to form that one continuous structure. This would be another way to look at it. And this is basically the frontal view looking right into the mouth. So we start with the maxillary prominences having to contribute to the roof of the mouth, right? And how the maxillary prominences contribute to the roof of the mouth is by giving rise to the palatal shelves, right? So now the structures in the oral cavity are going to all kind of participate. They're going to play hand in hand to make sure that the palatal shelves can fuse with each other. So like I shared, you're going to have looking at these images 1, 2, and 3. In orange would be the palatal shelves, in red would be the tongue. So what happens is you can kind of see those palatal shelves. Remember how we said there was kind of fusion and movement in the horizontal plane and in the vertical plane. So what's missing here is the mandible, right? So the mandible would grow downward and forward. It gets out of the way, and of course, as it's growing downward and forward, also gets larger, kind of creating more space of that oral cavity region. So in this first image, you notice the palatal shelves coming in, right? And before they can fuse with each other, you notice that transition between images 1, 2, and 3, where this tongue in red starts to move lower and lower and lower till it gets to its final position in image 3. So the mandible moved down and forward, so the tongue could move down, so that then these structures in orange, or the palatal shells, they can come together and to kind of take on their horizontal position. And by the time you're in image 2, you notice that the palatal shells have taken on their horizontal position, and they will ultimately fuse by the 10th week of development. And when all of this happens, so when the tongue moves down to its spot, the palatal shells are able to fuse in that horizontal direction. In the vertical plane, you have the nasal septum coming down to be able to fuse here as well. And when all of this sort of happens, ossification of the palate will then occur, where that's where I mentioned it kind of zips up in an antero-posterior direction. But of course, you know that the posterior region does not ossify. Instead, it extends kind of past the nasal septum to sort of fuse and form the region of the soft palate and the uvula, and these are the final portions to form. And in this middle region over here, labeled the incisive foramen, basically this marks the midline sort of landmark between the primary palate, this tiny bit in yellow up here, and the rest of this big structure over here, which is the secondary palate. And finally, some clinical considerations to take note of in the event of any sort of anomaly during the development of the palate. Of course, the most common would be cleft palates or cleft lips. And of course, depending on the severity of such clefts, there might be clinical implications to things like speech and even to eating. So remember, we have the incisive foramen, right? So I mentioned a minute ago that it's considered the dividing landmark between the hard and soft palates. It's also the dividing landmark between anterior and posterior cleft deformities. So clefts that occur anterior to the incisive foramen might include things like a cleft of the lip, like up here on the top left. So this is a cleft of the lip, or it could even include like this image here in the bottom left, which is a cleft of the maxilla, so the maxillary bone is involved, or even clefts between the primary and secondary palates. And these clinical defects are due to a partial or even sometimes complete lack of fusion of the maxillary prominences with the medial nasal prominences, either on one side or sometimes even both sides. And everything else that lies posterior to the incisive palate will include things like clefting of the secondary palate, and even sometimes it could go as far back as to include the uvula, so you could have clefting of the uvula as well. But a cleft palate can also be the result of a lack of fusion of those palatine shells that we saw. And if, in the case that the palatal shells don't fuse together, it might be due to something like the smallness of the shelf. So they were too small to be able to actually fully come together to be able to fuse, or the palatal shelves might have failed to elevate and to take on that horizontal position they needed to take, and so they couldn't fuse. Or it could even be attributed to things like, say, if there's failure of the tongue to drop between the palatal shelves because there is micrognathia, spelled as micrognathia. So in the event of micrognathia, if the tongue doesn't drop down from between the shelves, they aren't able to take on that proper full horizontal position, and they aren't able to fuse. A third category of clefts may be formed by a combination of clefts that lie anterior to the incisive foramen as well as posterior to the incisive foramen. Anterior clefts, of course, might vary in severity from something that is a barely visible defect in the vermilion of the lip, to, it might even extend up into the nose. And in more severe cases, the clefts tend to extend kind of to a deeper level, and they form a cleft of the upper jaw. And basically when that happens, the maxilla is kind of split between where the lateral incisor sits and where the canine tooth splits. So there is that split. And frequently, such clefts tend to extend all the way through to the incisive foramen. And just as much as anterior clefts might vary in severity, those posterior clefts might, of course, also vary in severity. And things like, oblique facial clefts might occur in the event that the maxillary prominence doesn't merge with its corresponding lateral nasal prominence. Of course, I don't have an image for this up here, but in the event that the maxillary prominence doesn't merge with its corresponding lateral nasal prominence, an oblique facial cleft is formed. And in this particular instance, sometimes the nasolacrimal duct might even be exposed up to the surface. Typically, if there is a cleft lip present, it's also kind of likely that a palatine defect might be present as well, because the philtrum of the upper lip actually contributes to the formation of the primary palate. So a unilateral cleft lip could very well run all the way through to the same side, the primary palate, and go so far back as the secondary palate. And of course, in the event that there is a bilateral cleft lip, so on both sides, it could occur as a result of, it could be the complete separation of the primary palate from the secondary palate during development. And a cleft palate might also occur if these two palatine shells that we had, they don't come together properly. Because as I mentioned earlier, the palatal shells need to come together, and they ossify sort of in an antero-posterior direction, right? They zip up front to back. So because of that sort of direction that it seals in, it is more common to have palatine clefts as you go further posterior onto the hard palate and extend onto the soft palate. So in reality, most of these clinical implications are relatively easy to fix when they occur in isolation. So things like surgical intervention can quite straightforwardly resolve a cleft. And depending on its severity, of course, resolving a cleft might in turn help to improve that individual's quality of life, perhaps their speech, how they eat, because of course a cleft lip or even a cleft palate can quite possibly impair oral functions. So things like, like food or drink might be able to flow into the nasal cavity, or that cleft might also disrupt speech articulation. Of course, in addition to reconstructive surgery to correct the clefting, in some instances, depending again, of course, on severity, orthodontic treatment or even speech therapy might be required to sort of help develop more fluent speech for the individual. All right, so thank you everyone for your time today. As before, if you have any questions, please feel free to email me at antskr@nus.edu.sg, or if you prefer to do it anonymously, just pop on to this bit.ly link. Apologies if there were construction noises in the background. All right, that's it. Have a good rest of your day. Bye, everyone.